For those who don't know me, I'm Chandra Cullen. I'm the vice chair for the Child Psychiatry Division, and very pleased to introduce our speaker today, Dr. Molly McClain, to talk about foundations of gender care. So Dr. McClain graduated with an MD and PH from Oregon Health Sciences University and completed family medicine residency at UNM. She is the residency program director here at UNM for family medicine. Since graduating from residency, she has had the honor of partnering with gender expansive individuals and communities within Albuquerque. And Dr. McClain is one of a few people in the state who works with gender expansive youth in addition to adults. And she feels that gender care is something that all clinicians can benefit from engaging with, and she loves to support clinicians in learning the background and skill necessary for this type of care. So thank you so much, Dr. McClain, and I'll turn it over to you.
Thank you so much. It always makes it so much easier to not actually see faces, because then I can just be talking to my computer, which is what I have been doing when I'm practicing my talk. So it actually makes me feel better. I am just really honored to be here. So excited. I'm Molly. My pronouns are she, her. And I also just have to admit that I am feeling a little silly and a lot nervous talking to such esteemed psychiatric colleagues about a DSM diagnosis. In my defense, it will soon be not in the DSM. Unfortunately, when the ICD-11 comes out, it's going to be moved into under sexual conditions, which I have my own issues about, but baby steps. But hopefully you guys all will get something out of this, and I just really am honored to be here. I'm gonna go ahead and start sharing my screen. And if anyone else has not yet figured out how to do presenter view on Zoom, I have a tip for you. It's like one of my favorite tricks. So be a little bit patient with me while I do my trick here. And I'm not seeing any faces, but could someone just holler out if you can see my screen? That would be really helpful.
Oh, yes, I can see it.
Okay, thank you so much. Great. So I initially was just going to speak generally about gender expansive people, but Dr. Cullen kind of suggested, and I think it would be great, kind of hit a lot of things talking a little bit more about youth. So I hope that that is what you are all expecting. We'll be starting with a case. I think this is a nice way to start talks. This is kind of how our brains expect talks to start. And these are the kinds of questions that will be covering the information. So if you, at the beginning of this talk, if these questions seem overwhelming or you wouldn't know how to answer them, then my hope is that through the talk, by the end of the talk, these questions will be easier for you to talk about and at least easier for you to find resources for. So Moth is a 13-year-old male who is designated female at birth, uses he, him, his pronouns, not on medical treatment for gender dysphoria or gender incongruence, who is presenting to clinic with mom to discuss gender incongruence. Moth has had a recent admission for suicide attempt, and mom is not sure that she, speaking about Moth, is ready for treatment for gender incongruence. So the questions that hopefully you'll be able to answer really well at the end of this talk is, what questions might help you get a better idea of how to support Moth and mom? Clearly Moth needs more support. He has had a recent admission. He's in a place in his life where he is feeling like being dead would be better than being alive. But as we'll see, helping mom do that work as well is a really important part of the medical intervention that we can perform. What questions might assist us in confirming a diagnosis? What information is needed in order to know what treatment option would be the most appropriate if Moth even wants medical treatment, which is not always true? And how might you best support mom in understanding how to affirm Moth? And again, helping families affirm their kids is one of the most important medical interventions that we can support. It's really probably the most important health, the most important factor in health outcomes for gender expansive youth who become gender expansive adults. For all gender expansive people, the most important determinant of health per the Lancet Journal is simply gender affirmation. So the most important determinant of health, it's not a fancy medication, it's not some kind of fancy training, it's not going to take a big lab to figure out. It is simply affirming someone's gender as they know it to be true. And so I think that's the most important place to start. Are folks still seeing my slides? Thumbs
Yes.
up.
Yes.
Thank you. Thanks. So gender expansive people have poor health outcomes compared to their cisgender counterparts of all ages. And this is not because of poor individual choice. It's not because of genetics. The fact that gender expansive people have higher rates of anxiety, depression, suicide, and involvement in survival economies has nothing to do with them being weak or inherently at risk of participating in those things, and everything to do with social and economic exclusion. As individuals, they are actually demonstrating very rational responses to an irrational culture that has precise and intense criteria for gender that, if transgressed, are often met with physical violence and even murder. Structural violence is a construct that refers to social structures or institutions that harm people by preventing them from meeting their basic needs. The harm is avoidable, causes increased illness, disability, and death, and it is invisible. Structural violence hides in things like differential hiring or promotion practices based on gender, differential incarceration rates based on skin color, and differential access to education based on wealth. So probably a lot of us have heard of the concept of structural determinants of health, but I actually prefer the term structural violence because it is more accurate and more precise. The term determinant, like, is it economic? Is it a natural force? Like, determinant sounds pretty determined, like you can't change this thing. So I think as the structural determinants of health is kind of, the term itself dilutes what it means, and I think it might dilute our drive to make things stop or be different. On the other hand, the term violence makes me uncomfortable, and I think that's part of what makes it helpful. I know what violence means, I know it's not good, and I know that I could probably find out what's happening and maybe try to stop it. And after hearing my patients talk about the tiny and giant ways that they are treated differently because of their gender, like the cartoon here on the slide, I do think violence is the most appropriate word to use. There's an excellent book on trauma called The Body Keeps the Score by Dr. Bessel van der Kolk. He describes trauma as not being seen or heard. And I think this sounds really hard for most of us to believe, especially in the medical world. We have these diagnostic criteria, PTSD being the primary one related to trauma, obviously, and we have very strict ideas about what trauma is. So we have more like being part of a war and having flashbacks, being physically attacked, these kinds of bigger things. But I think it makes sense. For humans, connection is survival. So it's actually a very smart animal nervous system that codes isolation as something dangerous, even life-threatening. And if you know that you have wings with gorgeous colors and you clean your antenna meticulously every day, and you just know that you're not a caterpillar, but you get told every day that you are, when your friends and family reject you because you aren't acting like a caterpillar, when your elementary school teacher shames you in front of the classroom because you keep lying about being a butterfly and you're not allowed to go to the butterfly bathroom, all of that is getting coded in our body mind as trauma, as not being seen or heard. In a clinical setting, if someone presents to clinic and their dead name is called out in the waiting room, or if they see in a note that their accurate gender or pronouns aren't being used, they are being told that they are a caterpillar by their medical provider, and they're also being told that they aren't safe in that space. And as we'll see later in the talk, use of accurate names and pronouns is actually a medical intervention that can save lives. Alternatively, use of dead names, dead gender, dead pronouns can have dramatically negative health outcomes. So, the social and economic exclusion that trans and gender non-conforming people face is another form of structural violence, and that becomes very clear when we look at the data. I think it's just an interesting kind of a case study for when we're thinking about constructs like structural determinants of health or structural violence, because the power of exclusion on health is really laid bare when looking at data for gender expansive folks, but the effects of inclusion are equally powerful and really quite revolutionary to consider. And I think understanding both of these sets of data is really important when we're working with families that have a gender expansive youth as part of that family. So in 2015, there was the second updated report of the US Transgender Survey. The first one was released in 2011. The one in 2015 had nearly 28,000 respondents, all of whom were trans or gender nonconforming. And this is really a deep analysis of every institution starting from the family. It included school data, employment data, carceral system, and medical system data. And some lowlights from this is kind of what I'm going to focus on. But if you're interested, they have a very well, it's a very easy to read executive summary, and the data is pretty harrowing. So in terms of family, 1 in 10 of the 28,000 respondents reported being violently attacked by their own family when they came out. 8% were kicked out of their homes, and 60% were significantly rejected. In terms of school, 78% of the respondents reported being bullied at school. In terms of employment, it's probably worse now, but 15% reported unemployment, and that's compared to 5% of the general population. And we did not fare any better in the healthcare system. So in the terms of the healthcare system, 28% reported that they had been refused care. And this is something that I hear about all the time. People saying like, we don't see your kind here, we don't treat your kind here. I found it hard to believe, and I still hear these cases, but I'm working with this group to like make a video to how you do a good interaction, how you like what a bad interaction might look like. And I thought that their example was just ridiculous. Like they had this example where the doctor was just like, what's wrong with you? Who are you? What are you doing? And I was like, that's just silly. Like no one does that anymore. Can we like make that a little toned down? But then just last week, one of my patients went to shall be unnamed emergency department here. And one of the physicians, when he said, you as a male should not be getting urinary tract infections, my patient was like, well, I'm trans, I was designated female at birth. And the doctor said, what? And then my patient said, I'm transgender. And the guy said, do you want me to call security? And my patient was just like so confused. He had no idea. And I was pretty stunned. Anyway, so that still happens last week in an ED in Albuquerque. So this is a very, very prominent and consistent problem. 50% of the respondents reported having to teach their doctors how to care for them. And the HIV rate was 5 times that of the general population. And that number was when they looked at the entire study of the 28,000. When they did a subgroup analysis among all the women in the study, that number jumped up to 3.4% from 1.4%, and then was even worse for women of color. So nearly 1 in 5 Black women were living with HIV. For American Indian women, it was 4.6, and Latina women, it was 4.4%. And again, just to clarify, this is not because being part of survival economy is someone's like biologically inherited weakness or some kind of choice. Being part of survival economy is because of the extent and the consistency of social and economic exclusion in every setting. 28% reported postponing care for fear of discrimination, and then 40% had reported attempt at suicide, and that's compared to 4.6 in the general population. So we can really see the health outcomes of exclusion here. Again, not biologically determined, but socially created. So that's all the bad news, but the good news is that this is all reversible. All of these things are things that we can intervene on and make different. What we know is that family affirmation, use of pronouns, and access to medication and surgery, if desired, can reverse most of these outcomes. So we'll start with the most important part, which is the family. One of the most powerful protective factors for gender expansive people is support and acceptance by the family. And the aptly named Family Acceptance Project is out of San Francisco State University. They've been doing some really interesting studies since at least 2009. And just to be real clear, the studies that they're doing are not on transgender youth alone. They are on LGBT youth. But I did look at the data, and it does include transgender people, which oftentimes, just because it's called LGBT, doesn't actually include trans folks a lot of times. But what they found was very interesting. They found that there was a direct gradient effect between extent of family support and health outcomes on sexual and gender minorities. So they determine level of family acceptance based on extensive interviews with family and youth. And then they have a rubric in which each participant gets a score between 0 to 55. 0 to 15 is low. 16 to 30 is moderate support, and then 31 to 55 is high support. They found that youth with more support from families had lower drug use, lower rates of anxiety and depression, and even lower lifetime suicide rates. The other piece of data that I really like to talk with families about is the American Academy of Pediatrics policy statement on gender care. It was the first policy statement that they published, but it's very powerful, very helpful. Also puts family support as a very, very important positive determinant of health. And some quotes from that study I found interesting. What is most important is for a parent to listen, to respect and support their child's self-expressed identity. These kinds of conversations may be difficult, but they are really key to the child's mental health and the family's resilience and well-being. Children who are supported by parents and family are more likely to experience better health outcomes. In one study, 56% of youth who identified as trans had suicidal ideation at some point, and 31% reported suicide attempt. And that's compared to 20 and 11% respectively in cisgender youth. The AAP recommends a gender-affirming, non-judgmental approach to help children feel safer as a buffer against a society that marginalizes and stigmatizes those seen as non-normative. And that's not my quote, that is from the policy paper itself. So these data really help us see how important it is to create support for the whole family when working with gender expansive youth. It is super important to try to bring the whole family together while at the same time not negating the youth's experience and also not negating the parents' usual very real concern just about the health of their kid and the future for their child. I always assume that parents just want the best for their child and that they might just be confused about whether or not supporting them in their gender identity is harmful or helpful. So I find these resources to be really helpful to help clarify for them that support, rather than trying to negate or eradicate their child's gender identity, is really the best way to go forward. To me, this is the most important thing that I can do for the health of that youth. It is not easy to navigate those conversations. I've come up with some kind of weird analogies that I like to use. And I think it's really important that parents don't feel like they're doing a bad thing, but they would be doing a good thing if they're supporting their child and their gender identity. Thankfully, because it's kind of a tricky conversation to have, the Family Acceptance Project has made flyers to help parents know what might be supportive versus harmful behavior in this regard. And it's just nice to have a little bit more specifics of kind of what things are supportive and what things aren't for people who really just have no idea. When you look at these, the behaviors that help versus the behaviors that hurt, you can see that they really just boil down to gender affirmation or gender rejection. In other words, I see you for who you really are, and I love you for who you really are, versus what you are is unacceptable, and you have to be different and not who you are in order to be worthy of love. And this shows, I think, the impact of truly being seen, heard, and unconditionally loved, and how necessary that is for all of our health and well-being. I think this data is actually kind of a really beautiful window into how unconditional regard and acceptance is so important to all people's health. So other supportive factors include accurate pronoun use and access to medications and surgery. Does anybody have questions so far? Comments, concerns? Cool, I will continue. In terms of pronouns, the paper that's linked at the top is one of the most impactful articles, it was for me anyway, around pronouns, and really the use of accurate pronouns as a medical intervention. So in this study, if gender expansive youth were called their accurate names and pronouns in one of 4 settings, if they were called their accurate name and pronouns at home or at school or at work or with friends, 1 of 4, their suicide attempt rate went down by 56%. And I'm saying that correctly, attempt and 56%. It might, I mean, if you want to look at the paper, the data might not be great, but the result that they came out with was the attempt rate went down by 56%. And I think that's really, really a dramatic improvement in something that's really important to all of us. And I think that use of pronouns when we introduce ourselves in all settings would really go a long way, not just to make the world feel safer for gender expansive people. I think it would really go a long way in starting to break down our strict cultural norms around gender that really restrict all of us. None of us are unaffected by the rules and regulations of our gender. And I think that it's a really interesting thing to think about how silent those things are, how assumed those things are, and really how harmful those things are. And so I know that it's vital that we use accurate names and pronouns with our gender expansive friends, colleagues, bosses, and patients. But if we could start using them all the time when we introduce ourselves all over the place, I really feel like the impact could be so much larger, really culturally changing and making people who are gender expansive feel safe and feel seen and heard and have all the health benefits that we've talked about. In terms of access, and I also need to say at this time, a self-disclosure, I have been doing work with gender expansive people for 4 years now, and I still struggle with this. I still forget to use my pronouns, and I keep trying. It is a simple intervention and it is not easy. And so I just want to acknowledge that. And the way that I do it, I had to work really hard because my brain was really used to saying something when I would walk into a room or introduce myself to people. And so now when I walk into a clinical room, I say, "Hi, I'm Molly, Dr. McClain. My pronouns are she, her. What would you like me to call you?" And I still sometimes have to practice that on the outside of the door before I go in, because it's still kind of, my brain still doesn't want to do it. In terms of access to medications, if desired, there is a lot of data about this. I've picked some of them. In the pediatric, I think it's the one on top, the HHS public access one, there is a lower lifetime risk of suicide if people were able to access puberty suppression if they wanted it. And to highlight where we're at in the world in terms of gender norms, as of April 2021, at least 18 states had introduced bills to criminalize or ban access to puberty blockade, hormone therapy, and gender confirmation surgeries. So again, even in the face of really strong evidence that access to these medications decreases lifetime suicide risk, our ideas of gender and what that means to some people really makes this gender dysphoria, incongruence, and treatment of that offensive to some people. In terms of intervenable factors associated with suicide risk, in the study from the BMC, intervenable factors in this study included social support, support from parents, and access to medical care. In other words, all three of those things improved people's mental health drastically. And I just put the picture of the Lancet on there, the 2016 series. I feel like this is just a really great place to start. There's a couple different articles in there. For me, it was the most clear time when I saw that they just have a little chart in there that says the most important thing is gender affirmation. And I think for some reason, just the simplicity of that really stuck with me, and the highlight of social and economic exclusion as the real problem. So that's a really great little series if you're interested. So now let's transition back to the clinical setting. But before we do that, I want to just do a quick interlude of some basics. And so basic vocabulary, it seems really tricky because these all seem really obvious, and actually they are. And so then I think people just get like really confused about, like, is this really easy? Is this as easy as it seems? So I'm going to ask some questions, and if no one feels comfortable sharing, then I'll just keep talking. So what is the significance when I say sex or gender designated at birth? Why would I have to say all those words? Why is designated or assigned at birth a helpful thing to add?
Because it's not necessarily congruent with what they identify as.
It's not congruent, yeah. And how does someone designate or assign our gender?
Genitalia.
Genitalia. They look at your genitalia, and as we very well know these days, genitalia, sometimes we have ambiguous genitalia. And then what do you do in terms of, like, you don't know what someone's gender is based on genitalia? And gender is a really complex construct based in lots of different things outside of our genitalia. And so when I say designated at birth or assigned at birth, I'm making it real clear that this is not a fact. It's not a given fact based on genitalia. Sexual orientation.
Hold on, I have a question.
Oh, sure, go for it.
Yeah, so obviously at birth, the baby cannot say, well, I feel like a girl or I feel like a boy. So
Yep.
which is, that would be very helpful probably. So you're saying that just genitalia, even if, the great majority of genitalia are not ambiguous, yeah, that's not appropriate to use that to assign?
Not at all. No, I think it's totally reasonable to assign at birth. Totally
Okay.
reasonable to designate at birth. Yeah, no, I would not advocate for asking a newborn what their gender is. And I don't think a newborn would be able to know, even if they could talk about it. What I'm saying is, let us all recognize that gender is not directly related necessarily to genitalia. And when we use words like designated or assigned, we're making it very clear that we're doing our best, doing it based on what we got in front of us, and things might change in the future. It is not a given. Does that make sense?
Would getting a chromosome typing to find out that at birth the girls have two X chromosomes and the boys have a Y chromosome change.
Why might that not be helpful? Why might that not always be clear?
Well, there's exceptions, of course. There
Yeah.
are syndromes where, but those are the minority.
That's true, and they exist. And so I think now what most people, the kind of the way that people conceptualize gender and race, they are two things that I think most of us have considered to be biologic, very determined, very set things. I think now most of us realize that there is a complex set of factors that end up in someone's gender or race. And that has a lot to do with biologic stuff like genetics. It has a lot to do with anatomic aspects like genitalia, but that's not the end of the story. And I think you're right. The minority isn't to say that that's what happens for everybody, but I think the minority, when you have genetic or chromosomal differences or anatomic differences, is to say we can't just assume that those are the only ways we can talk about gender or determine gender or race for that matter.
Okay, thank you.
Sure. And I'm happy to provide more evidence. There are some really great papers. I didn't want to go into it that much today, but there's a lot of great papers that kind of flesh out more about why most medical providers and social scientists don't think about gender that way anymore. We really think about it as a spectrum based on lots of different complex factors. And I would be happy to provide that if it's interesting to anybody. Cool. So orientation, super easy, I hope. What does it mean?
Who you're attracted to?
Yeah, who you want to orient yourself to. And that doesn't mean that you definitely want to do it, just like who you're attracted to. That's perfect. Gender identity. These are all as easy as they seem. Don't be scared.
The gender in which they identify with.
Yes. See, if you just repeat the words, you come up with the exact definition. I do think it's important, though, that as simple as they are, I think a lot of us, because they get conflated a lot, in our minds, they get conflated. Do you know what someone's sexual orientation is based on the gender that they were designated at birth?
No.
Yeah, anything to do with each other? No, they really don't. And that's why the term, I think, LGBT makes it really confusing for us to think about it, because lesbian, gay, bisexual are sexual orientations that has nothing to do with gender, and transgender is a gender identity. That's, I mean, not really, it can be, but it's a gender identity versus an orientation. I think it gets confusing, and that's why I break them out like this. What about transition? What am I meaning? What do I mean by that? I will admit, I don't love this word anymore. I'm kind of stuck with it. I can't think of a better one. I don't love transition because it implies that there's going to be some end. Like at some point, a person will be fully female, or at some point someone will have transitioned to fully male. And I don't love it, but it's still the most common terminology that we use for folks who are moving into their true identity, their true gender. And that can be broken down to social transition, medical transition, or surgical transition. And not everybody wants to do any of those things. And so it's also really, I think, exciting and hard to work with gender expansive people because we don't get to assume anything. And so all aspects, social, medical, and surgical goals of care are really different for each individual. What does cisgender mean?
You identify with what you were assigned at birth.
Right, and it harkens back to organic chemistry. I don't mean to traumatize anybody, but it really is when the functional groups are on the same side of the carbon chain. And so I was designated female at birth, and I identify as a female. I've never thought about anything else. It's just never even occurred to me. And that is what cisgender is. Because I am cisgender, do you know what kinds of people I am oriented towards? No. All totally separate from each other. Yeah, exactly. But it's confusing. Transgender now is less of an umbrella term. It wouldn't be offensive to anybody, but it's kind of more if people were designated female at birth and they are male in real life, like the opposite. Whereas folks who are gender non-conforming, gender non-binary, really are just something else. Like you don't have to be the opposite. And sometimes the diagnostic criteria can make that a little bit tricky because they have very specific wording that makes it be the opposite. And so it's not always opposite. Sometimes people just don't agree that there should be a gender binary, and they believe and feel and know that they are part of that spectrum. And then the significance of dysphoria and incongruence is that gender dysphoria is currently the diagnostic term. And when the ICD-11 comes out, it's going to be transitioned to something called gender incongruence, specifically because currently the concept of dysphoria means that supposedly in order to get treatment, you have to feel real miserable. And some people don't feel miserable. They just know that their gender does not match what they were designated at birth. And so they don't like the B portion of the Dsm criteria. And so that will be taken away. It will be incongruence rather than dysphoria, because it just doesn't match rather than being dysphoric causing. And again, it will be a sexual problem instead, which whatever, we're getting there. Terms to avoid: transsexual, transgendered. That's just not how we talk about humans. So it's a person and their gender identity. Male to female and female to male, again, just erases folks who are non-binary. And it's really just not how people describe themselves. So I do not like that. And I just don't know, when someone says transgender male or transgender female, I don't really know what that means. Like, what were they designated at birth and what are they now? I don't know. And again, most people don't identify themselves in this way either. Some people do, and then I'll put it in my note, and that's what I'm gonna say their gender is and know that their gender is. But to me, like in a note especially, I just don't know what that means. It's just not super clear.
Dr. McClain?
Yeah.
Can I interrupt you just because
Please.
this is an important piece for me? I try to be very mindful when it comes to documentation, and I still use male to female, female to male, because I don't know what else to use. And maybe you're going to cover this.
I will, because I think that's exactly right. I think most people just don't know. And then we get really caught up, like, here, I've just said all these scary things, like you're going to kill someone if you don't say the right thing. And so I think it's really important to know what best practices are, and also to know that you're doing your best and you're just trying. I think all of those things are really important. So best practices for what to include in a note is kind of what I had in the first case, and we'll go back to that at the end. But ask the patient their name, ask the patient their gender, and ask the patient their pronouns. And that's what you're going to use in your talking with them, in your thinking about them, and in your note. And so when it's really important to, so it would be like, for example, Moth is a 13-year-old male, and I only know that because I asked. Designated female at birth, comma, he, him. I don't like using preferred either, because mine is she, her. Like, it's not preferred, it just is my pronoun. So I'll say the gender that they told me, what they were designated at birth because they told me that, and their pronouns that they use because they told me that. It is really important to not use people's dead names, dead pronouns, or inaccurate gender when you talk with them and in your note. And it's so interesting. I see so many people all over UNM and from outside referrals, like they'll start really well, and then in the rest of the note, they don't continue the pronouns. Like, that person's pronouns are always what they say they are, and their name is always what they say they are. And so it just should be consistent. And when you put their dead name in, or when you put their dead name in and like their actual name and pronouns, that's also like, they can see our notes, and that feels really demeaning, like in quotes their actual name or quotes their pronoun. I think it just diminishes the reality. You're kind of saying it's not really real. Their dead name is their real name, but that's not true for them. And so I think as much as you can be consistent and ask gender, ask pronouns, ask name, you're going to be much more safe than anything else, I think. And it's just like medically more accurate. I know what they're designated at birth, and I know what their gender is. So I just think it's more helpful and more accurate. This can be really cognitively difficult to adjust to in your notes if they use pronouns like they, them, and it, its. I have some patients whose pronouns are it, its, and I want to honor that, and I just mess up sometimes. And when I do that, I say, I'm so sorry, and I'll move on. When I introduced myself today in front of all of you, I said, you guys. I never say you guys. I said that probably because I'm super nervous, but I've tried to get rid of that kind of language for myself too, just because my brain I can't adjust, like in clinic do one thing and outside the clinic do another thing. But it's really important, that's particularly in your notes, that a lot of people can see now that you're being consistent with your pronouns, even if it makes your brain kind of hurt a little bit, because it can, and it's kind of cool. It expands our consciousness. Other basics include CDC's Youth Risk Behavior Survey of 2017. 19 different states for the first time included gender nonconforming and trans as an option for people to select as their gender. And in that survey, 1.8% of adolescents identified as trans or gender nonconforming, which is considerably higher than previous estimates, and also considerably higher than estimates of adults. And it's interesting because we have to use estimates because that's all we got, because most systems, most EMRs, most surveys don't include trans or non-conforming as a gender option. And so that is, I think, like a intentional thing. And I think we're doing a much better job at UNM to include trans folk and trans identities, but it makes it really hard to figure out numbers and stuff like that. Per the American
Oh,
Academy.
Dr. McClain, I'm sorry,
No,
can I ask a question about using it?
Yeah.
Because I'll say, like, for example, if I had a parent come in, they and them, I mean, it's just a little cognitively tricky because I think of it as a plural, but I don't know, somehow it makes me more worried, like a depressed person be like, just call me it, like they have, or like if a parent was calling a child it,
Yeah.
and that's not what the child wanted, I would
Oh,
find that
yeah.
as like a big red flag. So could you speak a little to that? Because I just hadn't heard of people referring to themselves as it so much. And to me, that sounds a little more worrisome, but I want to be respectful of their wishes. So could you speak to that a little?
Yeah, of course. I thank you so much for asking that question, because when I first had that occurrence, I was just like, okay, that doesn't sound good at all. Are you okay? And the first patient who told me that their pronouns were it's had gone to law school, is super successful, is in a great partnership. It has other identities. Other kin is something that I don't quite know, but I think it means something, and I don't mean to dishonor it, I just don't understand it that well. I think it means that they are in familial connections with things other than humans, and maybe things other, like online things. And so after talking to this patient, like, it is just amazingly intelligent, and it has a political and personal, like, that's a very important part of its political and personal identity. And I think your concern is completely appropriate. I would never be okay with someone else calling someone that. But I think some investigation around where they are at in terms of their identity, in terms of their joy in life, would be totally relevant. I think that's relevant for all of us, but I think you're exactly right that it was an indicator to me that something was amiss. And so after investigation, nothing was amiss. That is just a very important part of their identity. And as you can see, probably even now, I'm struggling to say it and it's in my sentence because it's cognitively just not natural for my brain. I don't have a problem with it as a pronoun, except for my brain has a problem with it as a pronoun. So I think that's a great question. And I just do my best to honor people's wishes. And I think you're right, do a good job as a medical provider to make sure you're not missing something in terms of depression, anxiety, and identity. So, but that's a really good point. So per the AAP in that policy statement, research supports that prepubertal children who assert that they are a gender not assigned at birth, they know and they are stable in their gender equally and consistently compared to developmentally equivalent cisgender peers. So in terms of persistence and consistence of diagnosis or gender identity, it seems that most youth, even at a very young age, have a pretty solid and stable idea, just as solid and stable as cisgender peers. So now let's jump back to the clinical realm. And I want to be attentive to timing. I'm sorry. You might have to skip through some stuff. So we've heard a little bit about moth, but the questions that included in that first slide were what might we want to know, and how can we confirm a diagnosis of gender incongruence, and how can we clarify gender goals? And really the bulk of our first visit is asking the basic HP questions, but then we also spend time on their gender journey and their goals of care, including whether or not they want medical treatment, whether or not they want surgery in the future. Gender affirmation or gender confirmation surgery is the terminology around that. So in addition to that whole very long, we usually spend an hour, and I feel really lucky for that. Then I also include the consent, which is here, and that's from the Endocrine Society. And I basically just whole hog stole it and I put it in my notes, and we'll go through the details. This is the outline of it, but there's more detail to it that we'll just skim over briefly. I don't have patients or families sign a different consent. This is the consent. This process and it being in the EMR is the consent. So we go through the Dsm criteria, which I'll show you in a sec. Mental capacity has to be assessed for the kid and the parent if they're under 18, because under 18, a parent has to be agreeing to the treatment. Although that is another thing that could be discussed at length. But for safety purposes, I'll just say 18 and under, you need a parent to also accept. We talk about the effects and side effects of hormone therapy. Or we talk about the effects and side effects of puberty blockade. We talk about medical contraindications, and then we assess whether or not folks are engaged in counseling. Per the Endocrine Society, being engaged in behavioral health is a very strong recommendation. It is not a requirement for medication. I strongly suggest to folks that they engage in behavioral health, all of my patients of all ages, but particularly youth with gender dysphoria, because they just have so many more barriers to their own joy. I myself have 2 therapists and find them very helpful, so I don't know how anyone survives without them. And I have a really great list from the Transgender Resource Center of great therapists who want to work with kids with gender dysphoria. And I'll give you the link to that whole resource page at the end. But they do not have to be engaged in counseling. They do not have to have a behavioral health provider diagnose them. I am a behavioral health provider as a medical doctor. And part of the reason I include the DSM criteria in this consent is because specifically around the more expensive puberty blockade, insurance companies will tell me that I'm not a behavioral health provider, despite the fact that I very much am. In fact, I told one poor person, he's like, well, couldn't you just write at the end, just like more words, like why are you qualified to do this? And I was like, friend, I spent $500,000 and the best years of my life getting that MD. That is all that needs to be on there. Let's carry on. But I think it just makes them feel better when the DSM criteria is in there. And I also just think it makes me feel better to know that they are meeting diagnostic criteria, despite the fact that diagnostic criteria change. So super quick. I'm talking even faster. Different criteria for children and adults. Most of these questions really can be answered just throughout the gender journey discussion. So that's usually pretty straightforward. But then let's say Moth does want medication. And so now we know he meets criteria, but how do we know if he indicated more for puberty blockade or hormone initiation?
I have a question.
Of course.
Thank you, Dr. McClain. So in terms of the mental capacity assessment, can you tell us, I mean, how far do you go and what are the things that you're looking for that would give you pause?
So I do a mental capacity similar to how any medical provider can do mental capacity anywhere. So I ask, if we start this medication, what might happen to your body? If we don't start this medication, what might happen to your body? And I talk to both the parent and the child about that. And so in terms of mental capacity, I feel reassured, even when kids are younger, that they have the ability to make a decision about what will happen to them. They can't, they might not have the power to know what the future holds. None of us do, but they know what will happen or what will not happen if they do or don't take the medication, which is exactly how we assess capacity for all people. And the benefit that I have, what makes me feel a little safer, is that I also do that for the parent, and the parent has to approve any starting of medications or any changing of medications. And so that to me helps me feel a little bit safer. It is a bit of a gray area. So I just do my best, which is determining capacity as I would in any other setting. I don't agree with calling psychiatrists to determine capacity unless it's confusing, just so you know. And I tell my residents the same thing.
So just to make sure, so capacity is really focused on that the person understands the benefits and risks of the particular medication or surgical treatment. It doesn't involve an examination of alternative explanations for why this person may want to change their gender, or not their gender, but change, their biology.
Right, but that's not what mental capacity is. I think mental capacity, just like you said, is a smaller piece, a very specific piece. The rest of the examination and the conversation that we're having all together really fleshes out that other question that you had about what could be happening? Is this real? Is this sustainable? And I benefit also from having the DSM criteria as a way to kind of feel safer that that's what we're talking about starting in terms of medication is indicated based on the DSM criteria itself.
So you use the DSM criteria that you showed us to say this kid has gender dysphoria, and then you assert that the kid is able to, express what the risks versus benefits of the treatment are.
Exactly.
And then you move forward.
Exactly. And that's based on the Endocrine Society guidelines for both youth and adults. And so again, I'm following guidelines. This thankfully is not something I had to make up by myself. I'm following accepted expert guidelines for the Endocrine Society. And that also is linked on our website that you can take a look at. Yeah, so someone asked in the chat about WPATH 7. I don't love WPATH. That I think the last recommendations were written in 2001. And so I just prefer the Endocrine Society guidelines, and I feel like they're just as binding and helpful. And so that's why I use the Endocrine Society guideline consent rather than the WPATH consent. That's a really good question though.
I've had to actually provide documentation and they've wanted it from WPATH. Have you, so the Endocrine Society that sort of will trump, will be able to.
It's gold standard now. WPATH is not considered gold standard because
it's
from 2001. And so if you ever, and I also in my website that I made, I have all my note templates, which include all of this stuff. And so it makes it really easy to do the exam, and it makes it really easy to make insurance companies happy. Because the consent form from the Endocrine Society of 2017 is more updated, more accurate, and more helpful. I've never had anyone tell me to use WPATH, and I wouldn't want to. And that my argument, I guess, would be that this is more updated.
Wonderful. Thank you. That's really helpful. Thanks.
That's weird. I will show you the website at the very end, and I think we'll get there. I'm going to cruise real fast. That's a good point. Let me do this really quick. So puberty blockade isn't something that you all, like the medical stuff, it seems like that's not something that most folks here anyway are interested in doing. So I just want to give you an idea. If you have patients on any of these things, puberty blockade is indicated if someone is at Tanner 2, maybe 3, but probably not. So you don't do anything before Tanner 2, and you probably don't want to do puberty blockade after Tanner 3 because it will induce pubertal reversal, which is similar to menopause and just hurts and sucks. So it's GnRH agonists. And again, we talk about the effects, the side effects, and there's a separate consent per the Endocrine Society guidelines. This is what I have in my note. So if you're interested in just kind of looking over that. So GnRH agonist treatment, all of these things are satisfied. And then I will highlight other clinician experienced in pubertal assessment down here. It does not have to be a pediatric endocrinologist. I did not make that up. That is from the Endocrine Society guidelines. If they are beyond 10 or 2 or 3, their body is physiologically ready. Their body's already going through puberty. And so hormone therapy is indicated. This is a picture of one of my patients. Yes, they gave me permission, and so did their guardian. She likes to get updates when I share her picture. So the black and white, which I think is beautiful, is before she started hormone therapy, and the picture on the right is after. She's one of my first patients that I had at DeSeo, and so she's also just a really special person. But for hormone therapy, I also go through, in addition to the Dsm criteria, I go through the consent aspect just from the Endocrine Society guidelines. Again, clinician experienced in pubertal induction. Masculinizing is really just testosterone. There's different formulations. This is the form that I use to go over the effects and side effects with the patient and the family. And it's just nice for them to have that as a kind of a guide of what to expect, not that it's 100%. Some of the irreversible effects of testosterone include clitoral enlargement, and then facial and hair body growth. I have only had 2 patients stop. I have about 1,500 patients. I've only ever had 2 patients stop, and it was not because they wanted to, it was because their family made it impossible for them to be who they were. So I don't have any experience with someone being on testosterone and stopping it. So I don't know if these are true. Most of the data that we have around gender care is really limited. And so we do a lot of informed consent, which is, this is what I got. Sorry, got to leave it up to you to make the decision, family. And then fertility is a really important thing to talk about with families when starting any of these medications. Feminizing hormones is a combination of spironolactone typically as a testosterone blocker, and then an addition of estradiol. And there are different ways to monitor that. If anyone ever has questions, if you're interested in doing this or learning more, I'm always available. I'm like on speed dial for a ton of people across the state, because I think it's so important that we just feel comfortable doing this if we're interested, and feel empowered to do this care, because it's super easy, it's super fun. If I can figure it out, anybody can, for reals. I was going to talk about the legal stuff. Age of consent, like I said, is 18 in this state. Name changing stuff like legal stuff, birth certificates, passports. I have templates for all that stuff if anyone ever needs it. Behavioral health is super important, I think, for all of us, but particularly for gender expansive youth and adults. And then there's a bunch of different surgical things that people can pursue. We don't have a lot of surgical options here in New Mexico, unfortunately, but our superintendent of insurance has mandated that insurance cover both medical and surgical treatment for gender dysphoria in this state, contrary to what Presbyterian insurance would have us believe. A little fight with them right now. So back to this slide. I just wanted to recheck it with everybody. Do you feel like now you might know a little bit more how to support moth and mom? Do you have a better idea about what questions might you ask or what resources you could go to confirm a diagnosis? A little bit about the information for treatment options. Tanner 2 is really the key. It's not the age. And then how might you support mom in understanding how best to affirm moth? I think for that, the Transgender Resource Center of New Mexico has some really great groups for parents and youth, and they are just amazing. It's all the groups are now on Zoom, which is also great, but they have been my partners. I wouldn't do my job. I couldn't have done my job or even started this whole thing without them, and so I really owe them a lot and really respect their group. The UNM FM Wiki clinical resources, that is the thing I keep referring to, that has note templates, lists of counselors. It has the masculinizing and feminizing thing. It has all sorts of stuff. The Endocrine Society guidelines, the UCSF primary care site, all that stuff is really helpful and it's all on there. And I'm panting a little bit and I'm 2 minutes over, but we did it. We got to the end. And I love all of your questions. I'm gonna go back to the chart here, or the chat. How do you handle when one parent is on board and other is not? This is super, super hard. There is no right answer to this. I do my best to help everybody be on board. If they have joint custody, they are both that kid's guardian. And so I do my best to bring both on board. If worse comes to worse, and if you have fear for that child's health, it is similar to having a diabetic child that is not receiving insulin. If one parent just feels that insulin is not appropriate and one parent does. And so in cases like that, I've never had to do it personally, but people in my group have had to get CYFD involved and get legal care involved. And so that's not optimal in terms of the family dynamics. But if you're worried about that kid and getting CYFD involved is necessary, that is an option. It just kind of totally sucks. And I worked with a family for 3 years. We had hour-long meetings for 3 years. And finally, dad decided that it would be okay to start Puberty Blockade. I think it was probably a little bit too late, but I just do my best to work with them and really try to understand where they're all coming from and then try to get them on the same boat. And sometimes it doesn't work ever, and sometimes it takes 3 years. Is any type of counseling sufficient? And do you follow up with your inpatients to assure that they've stayed engaged in counseling? No.
Yeah, that's me, Dr. McClain.
Yeah, go for
Sorry
it.
to interrupt you. I just wanted to ask if you can, since you're talking to a group of mental health practitioners, is there, and I'm sorry, I don't know this, but is there any best practice or recommendation for types of psychotherapeutic support for individuals with these concerns?
That's a great question. I think that what happens a lot of times, I think the most important thing is that practitioners, kind of like medical providers, just know about gender stuff and have an idea of how it might affect people without pigeonholing people and saying, oh, it's because you're trans. I think people who are transgender, just like all of us, have all the same stuff and all the same issues, and they don't want to have someone pin it all on them being transgender. And I don't think it really changes care in terms of behavioral health. I prefer folks who are trauma informed, just because of the extent, like you see so much like medical outcome and behavioral health outcome of trauma. And it's been really confusing and hard for me to figure out where it's coming from. And I finally figured out that it's from trauma. And trauma informed is a tricky thing because it doesn't mean the same thing to everybody. And so it actually is really hard to get adults and kids into appropriate therapy that's helpful. But I don't think there's a best practices. Someone who cares and someone who listens and someone who's helpful really is the thing I think is important. And the list that I have on my wiki site, those have all been vetted by the Transgender Resource Center. And I think that kind of stuff is probably the most important, not their practices necessarily. I talk a lot about EMDR and internal family systems and stuff like that, but it's hard to find practitioners who do that and counselors. And so mostly for my patients, it's just if it's helpful or not. And if they feel seen and heard and if they're getting getting outcomes from it. And I don't make them do it. It's totally up to them, just like any of my patients are. It's not a gate or a barrier to getting access to medication.
Thank you for the information. Thank you for this excellent talk. Dr. Kreichman also has a really neat question about how do you help the school best support a gender fluid student?
That is a good question. And I've never had to do that before, but that is a fantastic question. My best advice for something like that would actually be to reach out to the Transgender Resource Center. They have so many more connections and like legal people and people in schools. And there's an organization called GLSEN, GLSEN. That would be a really good resource too. But my suggestion would be to call the Transgender Resource Center. Super easy to find on the web. I do not know it offhand, but they have a great set of social workers who could help figure out how to do that. And also legal stuff if that becomes necessary, if they unfortunately are not interested in participating in the changes that they might need to make. Youths at age 14 are able to seek medical treatment without consent. It totally does apply here. Some people feel comfortable doing medical treatment for gender dysphoria for kids who are under 18. I don't. The law is fuzzy in terms of gender dysphoria. Similar to all of us, everyone's still confused about, is it really a DSM? Like, should it be under the behavioral health realm or should it be something else? People who feel strongly that it should be under the behavioral health realm and they really want to treat kids who are between 14 and 18 or even younger, will use the behavioral health kind of caveat to treat kids without parental consent. Because of how important family support is, I am more concerned that the family participates and is happy about it, or at least willing. And I'm also really scared that I'm going to put some kid at risk if I treat them for gender dysphoria and they have physical or visible changes based on that medication, and that can put them at risk for violence in the home or being kicked out of the home. And so weirdly enough too, it just hasn't really happened that much. At DeSeo, I have this very interesting population of families, and we have about 500 patients. And these families just come in and they're like, yeah, cool, just give me the information. I feel kind of weird about this. Or they're like, this is the best thing in the world. But as it makes sense, not a ton of families are coming in, bringing their child in who are really unhappy about the idea. And so I think I'm not getting access to a lot of kids whose parents aren't supportive. And so I reached out to APS at some point, to the Albuquerque public schools, but I haven't come across that much. But technically you could, but I think just given how important familial support is and how scary it could be if a kid started transitioning without support, I prefer not to, but technically you can. Yeah, so gender fluid youth are highest risk for teen dating and intimate partner violence. I think that's a really important thing. So on one hand, knowing the data is really important and knowing what to screen for. I ask lots of invasive questions. I try not to do it on my first visit because it gets real invasive real fast. But yes, I think screening, and we talk about relationships, we talk about safety, we talk about safety in all settings. And I think it's really important to screen while also not assuming that our patients are going to follow the data. For example, the people living with HIV in our clinic population is like none. I mean, even at all of Truman, there are kind of a handful of people living with HIV who are transgender, and that flies in the face of all the data. And so I think when we have the data in front of us, it's important to be informed by it, but also not assume that our patients are going to fall into that criteria. And so I love your framing of it as a screening question. And that's a really important thing to talk about every time. Safety in the home, safety in relationships, who are your people, how's all that stuff going? And the more non-judgmental and open you are about asking those questions, the more likely it is that they will talk. Give up the goods. In learning about the charting process as a student and working with pediatric patients, I have come across the aspect that patients can see the charting. Yep, yes, they can. There have been some patients who have identities that they have not disclosed to parents. Oh, navigate, that's great. So at age, I think it's either 12 or 14 in our system, parents no longer have access to the chart. So from 12, once a kid turns 12, on to the time that they're 18, that chart cannot be seen by the parent unless the parent wants access to it, and they have to apply for like special dispensation to do that. So if you are working with a kid above 12, then you are safe. If you are working with a kid below 12, I would probably talk to your clinic director and medical records to see if there's any way to restrict patient access or parent access. But before 12, parents in our system do have access to the chart. And so that's a really important thing to think about. We do have a new thing. I think we have a new note template that is a confidential note template. We do in family medicine anyway. And so that might be another option for you to look into. But that's a great question.
You know, Dr. McClain, this has been, the time has gone so
Yes.
fast because it was so interesting and I love all the discussion, but it is too. So thank you so much for joining us today. I'm guessing you'll have people reaching out to you as questions and definitely utilizing you as a resource. So thank you so much.
Anytime, anytime. Thank you so much for having me. Thanks for all the questions.
Thank you.
Have a good day.